Moving into the risk stratifying, updates on risk stratifying for dementia, I think, especially in light of what we were just saying, where we've lost decades of time, research, advancement, like we know almost nothing more than we did 20, 25 years ago, other than chasing plaques and tangles, the physiologic anatomical changes to an Alzheimer's brain where you get these plaques and tangles. We used to think that was the cause, and what we're finding is it's a late finding and it's way downstream, and it's something far different, and that preventing and targeting these plaques and tangles doesn't do anything. And that's all we've been focused on for 20 years. It's transparently, in my estimation, and people who I admire who are thought leaders here, it is the single greatest failure in all of medicine to date.
Wow.
That something this significant, number 7 killer, that we are absolutely no further along over the last 20 to 30 years.
Yeah.
It's wild.
Especially for a disease like this that really doesn't discriminate, right? Like
No.
we have statistics on risk stratification for other diseases like heart disease,
Sure.
Based on race, gender, all those things. But like, I don't know that we can definitively say like women get Alzheimer's more than men. And maybe I'm just not up to date on those statistics, but it seems to me like it's non-discriminatory.
Yeah, at this point, there's nothing compelling.
Yeah.
I think in situations like this, and there are other situations that are like this in medicine, many actually. It's just none that I'm aware of that are this emotionally charged.
Yeah.
I think that you must, in situations like this, start with what you know. And what do we know to be true? And for some of you listening, this may be old news. Some of you, it may be a great reminder. And for others, it may be the first time that you're hearing some of these things. But here are what we know, and that is that it appears that screening and diagnostics, so in other words, being able to identify it earlier, which we may be seeing some incremental improvement in that with early imaging, neurologic testing, cognitive decline screening. It's fair to say we're making advancement in early detection or flagging, red flagging, caution, caution, caution. But it's not changing the outcome because we're missing something that is very significant. As we were prepping for this, I used an analogy and it seemed to resonate with you, and I really like it the more I think about it. It's almost like we have become, if we were really, really, really good at identifying and diagnosing pneumonia, that doesn't do any good unless you have antibiotics that kill the pneumonia.
Right.
We just become aware of the thing that ultimately will kill you earlier. Is that better or worse? I don't know.
Right.
But we can potentially identify high-risk people. We can potentially tag them early and say, it's started. And our best effort is to add some Aricept or that class of medicine to hopefully, if we're lucky, have it slow the progression of the disease. But there is nothing in our arsenal to reverse it or to cure it or prevent it. And that is a grim situation. So that basically means that we need some breakthrough in either therapeutics, in modifiable risk factors, like what can we actually do? I think the greatest area of potential breakthrough is in the modifiable risk factors. There is a growing body of evidence and thought leaders who are believing that Alzheimer's dementia is more of a diabetes type 3.
I've heard that before.
Specifically insulin resistance at the level of the brain, which is a fascinating concept to me. That's not settled science, but it is very compelling and it's very intriguing and it's plausible. If that were the case, then modifiable risk factors would be the same modifiable risk factors that we give you for cardiovascular disease, metabolic disease, cancer, modifiable risk stratification. So, all the classic things. As we're talking about it, what are the modifiable risk factors that we look at for things like the vascular dementia? And
Sure. So vascular dementia, it's more the kind of like what we look at for cardiovascular disease. So it would be the blood pressure, hypertension, know your numbers, get that under control, control diabetes, or the metabolic conditions of elevated insulin, elevated hemoglobin A1C, elevated blood sugar, smoking.
big time.
So quit smoking. A really huge one that we're zeroing in on now is lipid management or cholesterol management. So, again, knowing your numbers, knowing your ApoB levels that we've talked about here before and getting those down. And also a history of traumatic brain injury or stroke that could lead to vascular dementia as well.
Yeah, vascular dementia just being, there's a vascular origin, so their vasculature delivers blood and oxygenated blood to tissue, so there's some compromise in that. So somebody who's had a stroke or traumatic brain injury or has diabetes or vascular disease because of the diabetes or smoking or high blood pressure, that's going to compromise blood flow. Therefore, there's going to be brain injury because of lack of oxygen.
I was listening to a podcast, and I can't remember who said it, but they were talking about brain health, and they said what's good for the heart is good for the brain.
Yeah.
And I really liked that analogy because it's like, you don't want to smoke. You want to keep your blood pressure under control. All of these things through diet, exercise, that we beat the drum about incessantly here. It's kind of connected.
Yeah, I mean, at minimum, it will help you modify your risks for vascular dementia. If we have some good fortune and we can prove and get some breakthrough that there is, in fact, an insulin resistance component to Alzheimer's type dementia, then these same efforts will also facilitate risk stratifying meaningfully towards Alzheimer's, which is the big gorilla in the room. When we talk about non-modifiable risk factors, I mean, I think as we look at all disease, age is number one, right? The longer we are on the planet, area under the curve, total exposure over total time, age is the number one driver of chronic disease, period, the end. It's above everything else. And we forget about that. Just the older we are, probability says the more at-bats, we're going to get some chronic disease. And dementia is certainly one of those. Both Alzheimer's and non-Alzheimer's type.
It's a mouthful.
It really is. What's unique around Alzheimer's is there seems to be a very clear genetic familial component.
This is fascinating to me.
We do see it run, not always, there's always a first, right? But we do see a strong correlation between family members where this disease shows up in subsequent generations, and it tends to be a little earlier and a little more aggressive each time. So a thorough family history is absolutely critical to have eyes on a potential unique risk that needs to be watched. And again, we can't treat it,
right?
But if we get eyes on it early, then we might be able to slow it down long enough to catch some sort of medical technological breakthrough on a therapeutic, which would be the hope at this point.
Right.
That's where my hope lies. Talk to us a little bit about, we uncovered some literature around the ApoE genotype, and this is really unique. This is probably the most significant, well-known scientific risk linked to this familial genetic aspect of Alzheimer's disease. And I think if you have not heard of ApoE, write this down. I mean,
Right.
this is a huge thing because we're not giving you a bunch of new stuff, but this is the newest of the significant stuff that people really need to hear about this.
Yeah, so we add this to our new member blood panels here because we feel like it's really important for our members to know their genotype. But it's ApoE. It's a blood test, and so we send it off to the lab. It comes back, and it will let us know there's these genotypes. So you'll get a copy from mom and a copy from dad, and they're labeled as like E2, E3, and E4. So we will look at a ApoE genotype, and we'll see if you are, for example, just E3 I'm E3/3, so I never had my ApoE tested until like a couple months ago, but now I know.
So you got one copy of ApoE3 from mom and the same
one from dad.
Gene. So your ApoE, one copy from mom and dad, it's a 3 and a 3.
Yep, I'm 3/3. And it's linked back to how your body, as I understand it, correct me if I'm wrong, processes lipids, right?
Yeah.
So it goes back to this theory of,
again, correlated, not causative,
Right.
but it's starting to build some pretty compelling evidence that this is, once again, lipidology, metabolic, energy metabolism. There's a lot going on here. And ApoE3, so a 3/3 would be considered
neutral.
a neutral risk factor because it's what we call wild type. It will be the most common type. It's what the average person will have, a 3 and a 3. What we really, and that wouldn't be very interesting if everyone was 3/3. Where it gets really interesting is if you don't have a 3 and a 3, you have either a 2 or a 4, or a 2 and a 2, or a 4 and a 4.
Yeah. So 2 is considered protective.
That's right.
Doesn't mean you're out of the woods. In a 4, you are at increased risk. And, I think we have to give the caveat here, the disclaimer here that, again, with anything genetic, what you do from a modifiable risk factor standpoint will either turn on or turn off those genes.
Yeah.
So if you're a 4/4, that puts you at increased risk. Does that mean
doesn't mean you're gonna get it.
destined to get
No, that's right.
Alzheimer's? We don't believe that to be true. It just means that, as we've talked about with offense versus defense before, you really need to stay on offense with your modifiable risk factors.
Yeah,
right?
like I'm thinking of an analogy right now. I mean, I have a genetic predisposition that you don't need to run a genotype on. You can just look at me and know that guy's at risk for melanoma. Right? I have a very... Now, I'm lucky because of the phenotype, the way the genes look, this is a phenotype, the light skin, freckles, Northern European descent, high risk for melanoma. Does that mean I'm going to get melanoma? No, it doesn't. I'm just high risk. Same thing with type 4. If you're a 4/4, it's a flag. Careful, careful, careful.
Right.
If you needed any extra motivation to stop smoking or lose weight or correct your insulin resistance, these risk factors compound. They are nonlinear, which means 1 + 1 doesn't equal 2. 1 + 1 might equal 74.
Right.
These are hockey stick, nonlinear, compounding risk factors over time.
Yeah.
And essentially getting an ApoE genotype, the reason we do it is we're hunting for 4. And you might not have a single copy of 4, which doesn't mean you won't get Alzheimer's. But if you have one copy versus 2 copies, you can understand at least some implied increased risk. And obviously having 2 copies is a stronger indicator than having a single copy.
Yes.
So if you're a 4/2 or a 4/3, that would be better than a 4/4. I think that's really, really important